Okay, let's talk about positive predictive value. Now, this is a question I got wrong on one of my test questions, and it was pretty silly because it makes sense when you think about the word positive predictive value. What it's asking you is basically a probability that a patient has disease given a positive result, and that's just the positive predictive value. And here I just found the formula for it if you're looking at it in box form. So the true positives over the true positives plus the false positives. So it makes sense that if there are more people with the disease, then you're probably going to find more true positives. And that's how you will also get a greater positive predictive value if the disease is more prevalent. Now, the opposite is true. If this is a rare disease, then the positive predictive value goes down. Now, that makes sense because you'll probably have more false positives, and so this will increase and make this whole value smaller. So don't get that wrong. Now, some of the questions you might get different prevalence numbers in terms of percentages. So just think about its prevalence relative to the other, and just remember that prevalence goes up with positive predictive value. And the opposite is true for negative predictive value. So if the prevalence is increasing, the negative predictive value goes down. Anyway, I hope that makes sense. Well, just take a look at that formula down here. If there's more people with the disease, there's probably going to be less true negatives out there, and probably more false negatives. So this value becomes a lot smaller, and then this one probably becomes greater. So you have that relationship where greater prevalence is associated with less negative predictive value. Okay, let's talk about depression. I'm going to talk about a few features of depression, but I might come back to explain more later. Just wanted to focus on some of the things that are a little bit less common, ones you might not think about. Okay. So some of the clinical features kind of play into the diagnosis. So I just put a picture of the common depression symptoms. And then in terms of diagnosis, you want this to have occurred over at a minimum 2 weeks and at least 5 of any of these symptoms. So things to also note that are not, I guess, on here specifically is the topic of REM sleep latency, and that comes up surprisingly frequently. And it came up on one of the questions I got. It's just one of the things you just have to memorize. I think it asked, of a feature of depression. There are several different options, but I thought for some reason that it was increased REM latency, but actually in depression you have decreased REM sleep latency, and what that's referring to is just the time to your first REM cycle. So in people with depression, that's decreased. And another interesting thing to note about depression is we typically think about depression in terms of very slowed down movements, just people being less active. And that refers to the psychomotor activity portion in the SIGI-CAPS diagnosis. But you can also have the opposite of that, have increased psychomotor activity and just be very fidgety, and hyperactive. So don't forget about that. That some patients with depression might be more active and not necessarily slow like you might think. And then also interesting to note is one of the lab findings. You wouldn't ever do this, but it did come up in a test question where theoretically, if you did test someone with depression for their serum cortisol levels, they would actually be increased, which is kind of interesting. And some of that probably relates to the fact that sometimes stress and trauma can be a trigger for depression. They're all interrelated, so that would make sense that cortisol levels would be increased. And there is some thought that like cortisol itself kind of is a little bit neurotoxic to the brain, and so that might play some roles in kind of the symptoms you might experience in depression. So that's kind of interesting. So things to remember is that REM latency is decreased, not increased. Okay, next, real quick, we're going to talk about factitious hypoglycemia. Correct that. And okay, so you might see cases on this in people who are healthcare workers or access to medications or to relatives with diabetes. I tend to find that the questions about this tend to be people who are younger. Now this I'm not sure about if this is true, but I do know that I do see from personal experience that the patients in these cases tend to be younger. In terms of clinical features, you might see that there are frequent visits to medical care, they refuse to release records, and there's something else going on that's motivating them to do this. There might be some stress going on due to college or some other stress in their job they mention. So that's something to pick up on. In terms of the lab findings, I found this nifty chart to help us think about it. So obviously, since we're talking about factitious hypoglycemia, they would have evidence on their labs of hypoglycemia, but also if you're suspecting, there's something else going on, that you might want to check insulin and see peptide levels. So the insulin would be high, and you would also check C-peptides as well. How that helps you is if they're taking insulin itself, you wouldn't see C-peptides on there because that's an exogenous source. If it's coming from yourself, like endogenously, then C-peptides would be high, as in this case. Now, the other thing to think about is that it could be an insulinoma. You would get similar results. But for insulinoma, this is rare, and you would see this in someone who's a lot older. So think about the whole situation, and then you might want to think about doing the next step, which is a sulfonylurea screen, and reviewing all the other medications. Make sure there's nothing else causing it. All right, ischemic hepatitis. Where do we get that? Well, this can show up if a patient has had a recent MI, cardiogenic shock, or basically any situation where you have hypovolemia, hyperperfusion, or hypoxemia to the liver. And some of the lab findings that would clue you into this are aminotransferase levels greater than 1,000, bilirubin shouldn't be too elevated. It should be relatively normal, but it may rise later, depending on when you're looking at it. Typically, this is associated with poor prognosis. And then something that tripped me up, and to take caution, is I thought perhaps this was all caused by amiodarone, but amiodarone doesn't typically cause such high levels of your AST and ALT. So you would want to think about ischemic hepatitis if the person had a recent MI. Okay, next, colon cancer. So something to think about with colon cancer is that the liver is a common site of metastasis. And in terms of management, you want to think about surgical resection. If the cancer, the mass itself, is obstructing the lumen of the colon, or if the metastasis is limited, like there's a set amount of identified masses that you can remove surgically. So you want to do that. Now I got tripped up on here because some of the options included palliative care, and I thought once you got metastasis, then maybe you only want to do palliative care. But again, if you think about if it's possible to remove, if there's only specific masses limited to the colon and the liver, then that's fine. And especially if this surgical resection can help provide relief from the obstruction. It could also be curative, like I said, if the metastasis is limited. So you only would think about palliative care only if this person couldn't tolerate surgery. All right, let's talk about normal pregnancy physiology. So some things clinically that you can see in pregnancy that outside of that would have been abnormal is dyspnea, hyperventilation, ankle edema, and heart murmur. So in terms of cardiac things, you might hear systolic murmur, and this is due to increased blood circulating. And also you might see physiologically decreased systemic vascular resistance, and you might hear increased heart rate and also increased cardiac output as well. Pulmonary-wise, you have an increased respiratory drive due to increased tidal volume. And one thing you might see on here is respiratory alkalosis, as well as low partial pressures of CO2. And now thyroid-wise, estrogen will stimulate production of TBG, and therefore you have more bound thyroid hormone, and that will tell your body to start producing more thyroid hormone, T4 and T3, which will feed back and suppress TSH. So this is all considered normal. Now, things to think about is not to be freaked out about the murmur. I know I certainly was unclear about that and considered that abnormal, but that is okay. And even if they have a murmur in association with feeling short of breath and things like that, I was kind of concerned for cardiac problems. But they do tend to have a respiratory alkalotic state, so that should be considered normal. And another key thing to point out is I didn't particularly realize that both T4 and T3 increase, so they both can, and then return suppressed TSH.